Welcome back, and let's talk about the major concepts in anatomy before we jump into the details. First of all, I would talk certainly about the anatomical position. Then I will talk about the different planes and the anatomy, and after that we will of course highlight the most important types of joints, and then we will conclude by talking about the structure of spinal nerves. The anatomical position is yet a very simple understanding concept. However, you need to be careful when we talk about it. The question is, why do we need it? Why do we need anatomical position? Simply because we need a reference. We need an agreement. We need an assumption. We need something that all the time is fixed, because people, they look and they describe the body in their language, and this language may differ, and the assumption what is superior or inferior, what is anterior, what is what are the relations between different structure could be different, and therefore scientists have agreed up on something we call it anatomical position. Now let me take you through this definition. The anatomical position is the standard reference. So let's agree up on this term. It is a reference position of the body used to describe the location of structures. And we assume that the body is standing erect, as you can see here in this diagram. The upper limbs by the sides, so they are not turned up or down, they are not flexed. Okay. The face and the palms. Let's talk about the face first. It looks forward. Look at the eyes. They look forward. They don't look upward. They don't look downward. And let's look at the hands as well. Okay, they look forward, and the thumb is turned this way. And finally, the feet, they are by the side. So the knees are not flexed. The hips are not flexed. The elbows and are not also flexed. So as you can see, this is the anatomical position. If you want to describe an injury here in the hand or in the thumb or even in the thigh, you would use and you would refer to this position, to the anatomical position. More on the anatomical position as we proceed, as I will be employing real examples to depict for you the best definition and explanation for the anatomical position. In this slide, I will just simply talk about the planes. As you know, planes are either vertical, running from up down, or they're running in a horizontal way. We have here two vertical planes. The blue one here is the sagittal, and the pink one here is the coronal. Also, we can call it the frontal. Now, either you cut the body into two halves, right and left. This is the sagittal plane that goes from anterior to posterior, and this plane divides the body into right and left parts. If you take the sagittal plane right in the midline here, you would have equal halves, equal right and left halves, and therefore we call this plane median sagittal plane, this one. But also you can take a sagittal plane not in the midline as it is here, but rather as it is in this section here. This is a sagittal plane, but it won't divide the body into two equal parts. We call this paramedian plane. Right. So this is the first vertical. The second vertical is this one, the coronal plane. Now the coronal plane is very interesting as it is different from the sagittal. It would divide the front, the face, okay, and all the body, going from this side there, from right to left or from the left to right. This is the way it passes your body, and it results, or it divides the body into anterior and posterior parts. So if I to ask you which plane divides the body into right and left parts, you would answer the sagittal plane. And if I to ask you which plane divides the body into anterior and posterior halves, that would be the frontal or coronal plane. And finally, we have this very simple horizontal plane that divides the body into superior and inferior parts. Also, more on the planes, of course, would be taken care of as we proceed on this lecture. Now, terms to describe anatomical terms that we use to describe structures in the body. The main idea here is to know not the translation of each word. I would rather like you to focus on their meaning in terms of their description. For example, I have explained this before, and I will explain it again to you. Suppose this is the sternum, and by the way, we are looking at a sagittal plane that depicting the vertebral column, the heart, which is going to be B here, C the aorta, descending aorta, and V the or D the vertebral column. Now, if I to ask you which of these structures is anterior, your answer should be the number A, okay, or this one, letter A, because it is the ultimate anterior. If I to ask you which one is posterior, your answer should be the vertebral column. So whatever is close to the vertebral column used to be posterior, and whatever close to the sternum or the abdomen and the in other parts of the body should be considered anterior. However, having said that, you need to appreciate the fact that anterior and posterior, they are relative terms. What does this mean? For example, if I had to ask you the heart, is it anterior or posterior? You should reply, the heart, is it anterior to what? If we are talking about the aorta here, so the heart is anterior to this structure. B is anterior to C. However, A is anterior to B. So as you can see, this is a relative description. A anterior to B, B is anterior to C, C is anterior to D, and therefore D is posterior to C, and C is posterior to B, and B is posterior to A. Now let's jump into the definition of medial and lateral. Medial and lateral describe the position of structures relative to the median sagittal plane and the sides of the body. Any structure situated nearer to the median plane of the body than another is said to be medial to the other. And of course, structure that lies further away from the median plane than another is said to be lateral to the other. The definition here is a bit not complicated, but it's not simple, and therefore I need here to simplify it by drawing some examples. Now let's draw the body here. This is the leg, this is the thigh, right? This is the pelvis. We will not go further than this, and this is the mid, of course, the midline, and somewhere here the umbilicus. Now I also gonna be drawing here structure called femoral vein, another structure called femoral artery, and another structure called femoral vein, femoral nerve, which is in fact, it's not going to be a tube, it would be rather bundles of nerves. Now these three structures are close to each other. If I to ask you about the neighbors of this, neighbors of the artery, what you gonna say? You would say that the vein, is it on the right? What would you say about the nerve? Is it on the left or on the right? You can't simply say they are right or left, because both of them, as you can see here, are on one side, because we have a reference here. It's the midline. Okay, this is the right side and this is the left side. So when you have structures on the same side and you want to describe their relations to each other, you won't say this is right and this is left. You need to use these terms, medial and lateral, and that's why in fact we use them, and therefore look how it's going to be much easier now. This blue structure, the vein, because it is the closest one to the midline, we call it medial. And look at this, the nerve, because the nerve is far away from the midline, it's far away from the midline, we call it the lateral. So this is lateral and this is medial. How about the red thing, the artery here? It is in the middle or intermediate. So medial, lateral, intermediate. The word relative, I would also highlight this word. What does this mean? It means there is no absolute medial and lateral per se. We are talking about the same, medial to what, lateral to what. And for and this example is clear. The vein here, okay, is medial. Medial to what? Medial to the artery and medial to the nerve. And the nerve is lateral to both of them. This is a very brief description to what is the meaning of medial and lateral. What you really need now is just to understand the fact that this is a relative description. Now also we will talk about superior and inferior as we proceed in this lecture. Now let's talk about superior and inferior. It is obvious that the skull or the head is superior in the anatomical position and the feet are inferior. And also superior and inferior are relative terms. For example, although the femur is in the lower limb, but it has this part. If you compare it to this part, and let's give this A and this is B, okay? A is superior to B yet this part is superior to this part, and B is still superior to this one is superior to the other one. Now let's just make some quick revision to what is medial, what is lateral. It goes without saying, it goes without any questions by default that the thumb in the anatomical position is lateral, and the little finger is medial. It's the opposite here in the foot. The big toe is medial and the little toe is lateral. All right, then let's talk about this example here. We have this bone is radius and the other bone here is the ulna. What do you think? Which one is lateral? Which one is medial? This is lateral and this is medial. You could have not even described them as right and left because they are on the same side. Both of them in this example are on the left side. Therefore, we need to know which one of them is close to the body. It is the medial and it is the ulna. And the which one is outside to the away from the, of course, the midline. It is the radius. Again, more examples. This is the fibula and this is the tibia. The fibula is lateral, the tibia is medial. Okay, so these are some examples of medial and lateral. Now the question is, if when you turn your hand, your thumb inside, okay, you're turning your palm down, what do you think? The thumb would become medial or it would stay lateral? Of course, you should answer that the thumb, regardless of the functional position, regardless of the way it presents to your clinic, you should refer to the thumb as a lateral structure and to the little finger as the medial structure. Proximal and distal are used with reference to being closer or farther from structure's origin, particularly in the limbs. In fact, we will take many examples about them. All my videos about the humerus, I already divides the bone into A, which is the upper part, and B, which is the lower part. This is very common, upper and lower, or superior and inferior. Also, we can we already discussed that just minutes ago. And also you can say what is closer here is the proximal part and B is the distal part. The most important example for proximal and distal, it's in the bones of the body. This is distal, this is proximal, and for the ulna as well as proximal and distal, and you will find them in my slides described as proximal and distal parts. Now, if you look at the phalanges, the skeleton of the fingers, you may notice that we have three of them, 1, 2, 3. Now in the anatomical position as it is presented here in this diagram, this one is distal and this one here is proximal, and the one in the middle, it is intermediate or middle. Now if you turn the fingers up, so you, as if you are indicating to the sky, that wouldn't change the fact that the tip of your fingers, that phalanx of the finger is still the distal one, and the one close to the palm of the hand is the proximal one. So again, the landmark here is the relativeness. Wherever you go, proximal, distal, superior, inferior, anterior, posterior, medial, lateral, these are relative terms should be followed: anterior to what, posterior to what, medial to what, lateral to what, and etc. Let's talk about caudal and cranial. These are terms that are associated with embryology, with development. The embryo has no anatomical position, and therefore to make it easier for us, we just refer to the part that gives off the head, cranial part, and to the part that develops into the tail. By the way, the embryo during its development would have developed a tail, then this tail would of course disappear, but still structures. This is the way we describe the embryo. What is close to the brain, it's cranial. What is close to the tail is caudal. Also superficial and deep. For example, the skin is superficial, however the bone is deep, and also they are relative terms. Now let's talk about joints. The definition of joints is very simple. It is when two bones or more become together, whether there is movement between them or not. At least we need to have two bones, for example, the glenoid cavity and the head of humerus. These are two bones. Also, we can have the three bones, such as the humerus, ulna, and radius, as they are coming together to form the elbow joint. Now, we have said the first part. We talked about the first part of the definition, and let's carry on here to talk about the movement. Joints, it's when two bones becoming together, whether there is movement between them or not. However, this definition leaves us with the fact that not all joints they move. Some of them obviously they don't move. We would talk about the movements later on. Now let's carry on talking about general aspects of joints. Now, this is bone A and this is bone B. So the definition is simple: two bones becoming close to each other. Now we would have a look between these two articulating bones. If there is space, we would call them synovial joints. If we look, and this is a coronal section in the skull, and this is bone A and this is bone B, as you can see here, this is a joint, and of course they are connected by, we look between the two articulating bones and we found fibrous tissue. Then this is fibrous joint. An example for fibrous joints are sutures. You just need to know that here in the skull we don't need mobility, we would rather need stability. We are forming a box to contain the brain. Therefore, I would be happy if you just take this as an example. We will not go into further details, as these details would be with you on the upcoming courses. If we look between the bones here, this is bone A and this is bone B, although it's the same bone, and we found between them cartilage. Then these are joints are cartilaginous joints. Now, this example here, you just need to know that growing bones before certain age, before puberty and before becoming full adult, okay, bones they do grow, and they grow by means of cartilage and of course other methods, but one of them is this metaphyseal plate, this one, and still this is a joint, and we are not talking here about movement, obviously, but we are talking about cartilaginous joints that does not move. Another example here is this one. This is bone A, this is bone B, and of course between them also fibrocartilage. Some people they call it fibrocartilaginous. Some people they classify cartilaginous joints into primary, secondary. It doesn't matter, it's not that important for this course. And let's just take this example, intervertebral disc between vertebrae, as we call them symphyses, and they are usually in the midline in the vertebral column, and also here symphyses, pubis between this bone, the right and left, of course, hip bones. You just need to know the names as an examples for cartilaginous joints. Now, because most of our joints, those are the shoulder joint, the elbow joint, the wrist joint, the superior and inferior radioulnar joint, the proximal metacarbopharyngeal joints, interphalangeal joints, proximal and distal. Those are the joints of the upper limb. Then, of course, the hip joint, the knee joint, the ankle joint. All these joints, these are major joints in your body. In fact, all the joints of the body in the upper limb and the lower limbs are synovial, except the inferior tibiofibular joint. There it is fibrous joint, and we will talk about it in the lower limb section. Now, therefore, because most joints in our body are synovial, I of course would talk about the synovial joints. Now, the synovial joints, as we mentioned before, this is bone A, this is bone B. Okay, two bones become together, and when we look between them, there is a space, of course, a potential space, and this space allows bones to move. So what we expecting from synovial joints, we expect them to move. They are highly mobile joints. Having said that, you need to appreciate the fact that not all synovial joints, they have the same range of movement. Some of them highly mobile joints, and some of them barely move. Now, what are the main important features of synovial joints? First of all, it is the presence of a space. If there is no space, I would assume to have fibrous tissue, cartilaginous tissue, and that would be again one of those types. However, if there is a space and there is no tissue, then this is a synovial joint. So the first and the most important feature of synovial joints, the presence of a space. What else? As you can see here, this is in blue here. I would just go over it. And here, the ends of the articulating bone, bone A and bone B, both of them are covered by this blue structure here in this diagram, which represents hyaline cartilage. Also, we call it articular cartilage. Why do we need it? Because we assume and we expect from this joint to move, then we need to protect the mobile bones in this case, and the best way to protect them is to cover them with hyaline cartilage. You can practice this at home. Take a drumstick of a chicken, remove the meat, and look at the ends of the drumstick bone. you would find that this bone at the ends it is shiny and smooth. This is the hyaline cartilage. So the second feature of synovial joints is the presence of hyaline cartilage. The third feature is this one. Bone A is connected to bone B by means of capsule. So this is the capsule, all right, and the capsule, it is like leather jacket. From outside it is tough fibrous tissue to protect, of course. From inside it has this fabric, gentle fabric that protects the body from inside. This is exactly what has been drawn here in red. I'm just going over it. We call it synovial membrane. So the capsule of any synovial joint has two parts: the outer tough and fibrous to protect, and the inner is synovial. So why do we need the synovial? The synovial, it secretes the synovial fluid that lubricates the articulating surfaces and of course minimizing the friction. Also, of course, the synovial fluid nourish and provide nutrients to the articular cartilage. In fact, the whole all synovial joints are named by this name after the synovial fluid. This lubricant will minimize the friction between the articulating bone, and it is essential to the development and to the activities of the joint itself. So those are the main features. We will talk about the ligaments as we reach ultimately the hip, the shoulder, elbow and wrist joints. We will I will elaborate more on these accessory ligaments, articular disc, and etc. So those were the main features of the synovial joints: the presence of a cavity, the articulating bones are covered by hyaline cartilage, the presence of a capsule that secretes synovial fluid, which lubricates and of course facilitates the movement and prevents from friction. Now, as I mentioned just minutes ago, synovial joints, they are all of them mobile, highly mobile joints, but not all of them can perform the same functions and movements, and therefore we have subtypes for the synovial joints. We have hinge joints, we have pivot joints, and we have ball and socket joints. Before we proceed, I would like to take you in this journey with me. Let's imagine that this is a sand on a beach, and I did ask you to draw to put a tennis ball here in its socket, and I'll ask you to let's repeat it here. Okay, so this ball here in its socket, how many movements you can move it without breaking the cup? Of course, you can move it this way, this way, this way, this way. Rotation, it's, for God's sake, it's a ball inside its socket. You can freely move this ball. Now, if you didn't get this example, I would also take you to another journey to the same beach. It will ask you to put a rectangle here, alright, and I'll ask you how many movement you can move this rectangle inside its cup without breaking it. Simply up and down. So rotation is not allowed. You will not be able to rotate this structure. Therefore, I think you got the message now. You understood that what really determines the movement of these structures are their shapes. For example, this is the hip bone of the femur. It is a ball, and this is the socket, which is the acetabulum here. They are nothing but this diagram, a socket and a ball. We call this type of joint, this is ball and socket. What do you think the hip joint in this case, how many movements it can perform? It would perform of course all movements. It is triaxial joint, triaxial, 3 axes. That is flexion, extension, that is one axis, adduction, abduction, another one, medial and lateral rotation is the last and third one. So what gave the shoulder joint its ability to move in and becoming triaxial joint is nothing but the shape of the articulating bones that formed the shoulder joint in the first place. Now if we go to this joint here, the lower end of the humerus with this, look here, this shape, alright, and the head of the radius. Now I would ask you again to imagine how many movement the elbow joint can move. It's either flexion this way, alright, or it's extension this way, flexion or extension. Why can't we rotate like this? Why can't we rotate? Simply because this part, this bone would be broke, and therefore the shape of the lower end of the humerus and the upper ends of this bone, the radius and the ulna, have determined the range of movement and the axis that this joint would work on, and therefore this joint is said to be uniaxial. What does this mean? It performs on one axis 2 movements, flexion and extension. Although the elbow joint is a great joint, huge joint, okay, complicated one, however, it performs only on one axis 2 movements. Also, we can go and talk about other joints. Here, this is the hip joint, we talked about it. And of course, this is the ultimate goal of today's lecture, which is the shoulder joint. You can see the ball here, and you would see here the socket. And I'm assuming now that you know what we shall expect from the shoulder joint, ball and socket, triaxial joint. And it means that this joint is acting on 3 axes with 6 movements. It is similar to the hip joint. It flexes, extends, as well as medial and laterally rotates, plus of course adduction and abduction. Now I would draw here the another joint, which is the wrist joint. The bones of the hand, the carpal bones, they form a concave shape, while the lower end of the radius would form a convex part. So convex and concave, they are similar to half an egg, right? Now if I ask you to draw here an egg, I'm not gonna I'm not an expert in drawing eggs, to be honest, but if I ask you to move an egg inside its cup without breaking its cup, how many movements you would move it? Forward, backward, and to the side, outside, inside, that's it. But never rotation, never rotation. You can't rotate the egg without breaking it. And therefore the wrist joint said to be ellipsoid. What does this mean? A convex and concave surfaces together, and this is a biaxial joint, and it performs flexion, extension, adduction, and of course abduction. So that was the wrist joint. Also we have here another uniaxial joint. It's the superior and inferior radio-ulnar joint. This is the head of radius, and by the way it is circular, and it receives the here from the ulna, and this is its cup, and of course there is another ligament here completes the notch. So as you can see it here, around the head of the radius there is annular ligament. You don't need to know it now, and therefore the head of the radius is just rotates within this ligament, producing what we call supination and pronation, and this is the superior radio-ulnar joint. It performs on one axis, it is rotation, supination, and pronation, the functions of this joint. So again, the main word in subtypes of synovial joints is this: the range of their movements is determined by their shapes, the shapes of the articulating bones, with ball and socket, socket being the triaxial joints that performs more than one function on different axes, and of course to go to the hinge joints where they are considered to be uniaxial, performing on one axis flexion and extension. Another example of uniaxial was this, the superior and inferior radio-ulnar joint. And of course I drawn here for you the wrist joint, of course, with here biaxial joint, wrist joint, which adduction, abduction, flexion and extension, two axes, and of course for movements. Now in this part of the lecture I will take you through different movements. I advise you to memorize these movements from pictures from my videos, and I talked about them in my live lectures, and I would certainly highlight the most important movements on joints. Before we proceed, you need to understand that the shoulder joint has 6 functions, while the elbow has only 2. The rest has 4, and for each joint the way we move is to be different from the other, and therefore you need to memorize certain functions on certain joints. The flexion of the shoulder is different from the flexion of the elbow, from the flexion of the wrist, although ultimately in flexion we decrease the angle, and in the extension we increase the angle. This is the shoulder joint, and by the next week you need to know everything about it. When it's the arm by side, this is said to be extension. When the arm moves forward like this way, it is said to be, of course, said to be flexion this way, and if it goes backward, this is extension. So flexion and extension at the shoulder joint is easy. Okay, now let's talk about the shoulder joint again. When you move the arm away from the body like this is abduction. This is abduction. When you bring it from abduction towards the body, this is adduction. This is adduction. What else? Also, the shoulder joint performs medial and lateral rotation here, and focus on the shoulder joint. Rotation, it is when this is the head of humerus here. I'll draw this bone here like this is the humerus. Okay, now this is anterior of the humerus, the lesser tubercle. Now, and this is the glenoid cavity. Now when we move the anterior surface, we move it outside, this is lateral rotation. When we move the anterior surface inside, this is medial rotation. Now it goes without saying that this bone here, the humerus, right, is connected to the forearm here. So if you move the humerus, certainly you would move the, of course, the forearm, and therefore when we ask the patient to perform medial rotation, lateral rotation, it would go outside the hand, the arm, the forearm, and it would go inward in medial rotation. Let's go back here. So I finished talking about the functions of the shoulder joint, as you can see. Here, and let's talk about other joints. This is the wrist joint. Okay, when you move, this is the body, this is the boundaries of the body. When you move the hand towards it, it's adduction. When you move it away from it, it is abduction. Also, it's easy here. This is the midline here. All right. When you move the thigh outside, it's abduction. Inside, it is adduction. What else? Now, most of you have asked me about this movement of the hip joint. Certainly, we will talk about it as we heading towards the lower limb. This is the hip joint. This is the hip joint, and again, this is the bone of the femur. This is the femoral bone. When we move the surface of this bone inside, this is medial rotation. When we move the anterior surface of this bone outside, this is lateral rotation. Look, this patient has moved his thigh inside, so this is medial rotation. However, the leg at the knee joint has went outside, so we are not looking at this, we evaluating this joint. This may confuse you. If you didn't get it by this explanation, leave it until we reach the lower limb. Supination and pronation. Supination, it is when the palms of your hand are looking up to the sky, and pronation when they look down to the ground, as when you use your hands to pray or to recite Al-Fatiha from the Holy Quran, or you pray for people. This is in our countries something you will understand what I'm talking about. So this is supination and pronation. Now, supination and pronation, you need to understand that they are taking place on the superior and inferior radioulnar joint. I'll take you back to these joints here. These joints. This one here, the elbow joint, does not perform rotation. So when we perform screw driving, opening the water tap, closing the water tap, putting on the car's engine, all these movements are combination between supination and pronation. It means rotation. And if this rotation does not occur at the elbow joint, because this joint is uniaxial flexion and extension, it does not occur at the shoulder joint because it's far away. Try to fix it, hold it, and perform supination and pronation. You will do this without even finding anything to prevent you. So the shoulder joint is not involved, the elbow joint is not involved. Let's talk about the wrist joint. The wrist joint, I told you, it's an ellipsoid joint. It is a convex and concave surfaces, also does not allow rotation. So I need you to understand that supination and pronation, they are the product of this joint, where the radius crosses over the ulna, taking with it the palmar surface either up or down, pronation and supination.